Alors, nous allons débuter la séance à proprement parler. Je vais laisser Michel présenter notre premier orateur, le docteur Anatoly Kotlovski.
Oui, donc, docteur Anatole Kotlovski, anciennement de Russie, qui va nous présenter sur les anastomoses magnétiques par compression, un aperçu du passé vers le futur, parce que dans les années 80, les groupes russes ont été très actifs en chirurgie pédiatrique viscérale, digestive et autres. Et Dr Anatole Kotlovski connaît bien ces équipes et il va donc nous raconter ce qui s'est passé dans cette équipe. Donc, il travaille maintenant à Brisbane, en Australie, et donc il est 10h30 du soir, 22h30 du soir, et c'est pour ça qu'on a décidé de l'entendre plutôt que plus tard. Merci.
Alors, avant de donner la parole au Dr Kotlovski, je me permets de rappeler aux orateurs, I'd like to remind the presenters, que les présentations sont d'une durée environ de 15 minutes, suivies d'une discussion. Presentations are supposed to last about 15 minutes with a discussion to follow. Merci.
Bonjour, mesdames and messieurs, dear colleagues. Thank you very much for the honor and privilege of inviting me to present here today. I'm a pediatric surgeon of Russian background who from the very beginning was involved in a pilot project on magnetic compression anastomosis that was conducted at Alma Mater, the Pilatov's Children's Hospital in Moscow about 30-40 years ago. This was the first experience with MCA in pediatric surgery, including extensive preclinical experiments and substantial clinical trials. Curiously, information of those studies was largely classified as confidential and only limited material was available for publication at that time. Last year, continuing my common interest in MCA with Professor Oliver Münster of Munich, with his inspiration and involving my former Moscow colleagues, we published manuscript eventually summarizing that past experience. Today, in view of more recent MCA development, I will outline the background and outcomes of our early experience, emphasizing the rationale for MCA expansion and highlighting the identified limitations. I would also like to share our ideas to stimulate further MCA advancement. To date, MCA publications have been increasing, which indicates growing interest in MCA applications on a broader spectrum in both pediatric and adult patients. In this context, there is a number of novel magnetic devices and MCA techniques which have been proposed with a particular focus on a minimally invasive approach. In the meantime, in what we may believe to be a modern and innovative development, MCA is actually derived from the concept of sutureless mechanical compression anastomosis that had been introduced about 2 centuries ago. Historically, the first intestinal compression anastomosis device tested in an animal experiment was reported by the legendary French surgeon Denance in 1827. In the late 19th century, the renowned John Murphy of the United States proposed his famous anastomosis button, which he evaluated in animal experiments and then extensively used in his clinical practice. In the 20th century, mechanical compression anastomosis was technically advanced with novel devices which were used by many surgeons around the world until the mid-80s to 90s. Among those innovators was Professor Kanshin of Moscow, who designed a very successful mechanical colorectal device and who also had his pioneering role in the parallel development of magnetic compression anastomosis. The first experimental study on intestinal MCA was reported by Kanshin and his team in 1978. In 1980, the first clinical MCA application for colorectal resection was reported by Jensen and his team from Holland. Following those historical reports, a pilot clinical experimental project undertaken at our Philadelphia Children's aimed to explore MCA applications for specific gastrointestinal and urinary conditions common in pediatric practice. Our preclinical studies on animal models included more than 250 MCA identifiable experiments, which were conducted in the digestive and urinary tract using various samarium cobalt magnets of variable geometrical shape, size, and magnetic force. The comparative evaluations involve control groups of corresponding hands-on anastomoses. The technical results demonstrated that performing MCA was feasible and simplified, particularly via an endoluminal approach and an unchallenging surgical access. The biomechanical and morphological studies confirmed the magnetic capability to form a secure MCA of superior anastomotic quality with high tensile strains, primary healing, and no resultant scarring, in contrast to sutured controls. In particular, tensile strength tests on the rabbit intestinal models showed that MCA bursting pressures at early postoperative intervals were almost twofold greater than in hands-on controls. The morphohistological evaluations demonstrated that MCA healing normally occurred within 7 to 10 days compared to sutured controls, which were typically associated with prolonged suppurative inflammation. This is an example of MCA between the ureter and urinary bladder in a canine model, which resembles the natural ureteric orifice just at 2 weeks post-op interval. In contrast, the sutured anastomosis showed ongoing inflammation. The histology confirmed the complete epithelialization and the MCA line, whereas intramural microabscesses around sutures were identifiable in the control specimen. However, failures to create a robust MCA were encountered in our experiments when applying insufficient or too powerful magnetic force in the presence of anastomotic tension. On the one hand, the use of magnets with low force was inadequate to attain reliable magnetic cooptation, resulting in a breakdown of the MCA construction. On the other hand, the use of forceful magnets led to focal tissue overload with tissue tearing effect, resulting in perforation. Considering MCA biological formation and the magnetic force applied, the primary healing was found to occur under optimal compression within defined parameters in a balance between the maximum force and its gradient. The compression gradient, essentially modulated by the rounded edges of magnets pressing surfaces, was the determining factor to shape the healing zone where enhanced lymphocyte migration and subsequent connective tissue proliferation developed. Synchronically, the maximum compression was mandated in the central zone to ensure reliable magnetic cooptation and to exponentially compress the subjective tissue to the point of desiccation, thus preventing suppurative inflammation within the healing zone. At the demarcation line, which is the inner anastomotic line, progress in epithelialization bridged the rim of the thin desiccated tissue and displaced it together with magnets into the lumen. Thus, the primary healing was completed. Taking into consideration the magnetic force, surface area, and radius of magnets pressing surfaces, as well as the anastomotic tissue tension, thickness, the compression parameters required for optimal MCA formation were calculated with engineering input. Accordingly, the maximum parameters were determined for intestinal and colorectal, and the minimum for urethral and ureterovesical models. The following clinical trials encompassed in total 98 MCA procedures with original techniques performed in 97 pediatric patients with various digestive and urinary conditions. MCA applications involve the use of samarium cobalt magnets of specific geometrical shape, size, and compression force according to the preclinical evaluations. The first was technique of non-operative esophageal recanalization, which was developed for treatment of short-length strictures using magnetic cylinders to ablate the underlying scar tissue by compression force while concurrently forming MCA. The technique was applied in 15 patients with congenital membrane, post-anastomotic stenosis, and corrosive strictures 5 to 15 millimeters in length. Successful restoration of esophageal patency was achieved in 9 patients. Esophageal perforation and restenosis occurred in 6 cases, all with corrosive strictures. A technique of non-operative ileostomy diversion was designed using flexible silicon-coated segmented magnetic blocks to form intestinal MCA of side-to-side type as a wide ileostomy bypass. The technique was used in 46 patients with double-barrel ileostomy, achieving successful MCA and effectively restoring intestinal passage in 44. In 2 cases, approximation of magnets, however, was unfeasible. The modified Svensson pull-through using flexible silicon-coated segmented magnetic rings was developed to form a low colorectal MCA in the treatment of Hirschsprung disease. The technique was applied in 10 patients with confirmed rectosigmoid agangliosis, achieving robust colorectal MCA with no leakage or subsequent stenosis in 8. Postoperative stenosis, however, occurred in 2 cases. A technique of extravesical ureteroneostomy by conventional open access was designed using small magnetic rings to form MCA between the ureter of full thickness and bladder submucosa in combination with Rich-Gregoire tunneling. The technique was employed in total 11 ureters in 10 children with vesico-ureteral reflux, achieving robust and functional neo-orifice in all. A technique of non-operative urethral recanalization for treatment of short-length strictures using small magnetic cylinders was designed analogically to esophageal recanalization to compress the underlying scar tissue while forming MCA within the healthy urethral wall. The technique was used in 5 patients with post-traumatic strictures less than 5 millimeters in length, achieving complete restoration of urethral patency in 4. Restenosis occurred in 1 case. And the technique of creating bulbomembranous MCA using small magnetic cylinders was designed in conjunction with open resection of more extensive urethral strictures. The technique was applied in 11 patients, achieving restoration of urethral patency in 8. Adverse outcomes occurred in 3 patients, including 1 anastomotic leak and 3 restenosis, 1 in the same patient after a leak. Summarizing clinical outcomes, MCA was successfully performed across all applications with beneficial effects in more than 85% of patients. MCA formation and magnets detachment normally occurred within 7 to 12 days. Specifically, high rates of successful outcomes, 95 to 100%, were achieved for ileostomy diversion and ureterocystoneostomy, respectively, and 73 to 80% for urethral recanalization and reconstruction and for Svensson pull-through. Lower rate of 60% only occurred after esophageal recanalization, with all adverse events noted in those patients with corrosive strictures. Also, this technique was successful in all cases for congenital and post-operative and post-anastomotic stenosis. Notably, all adverse outcomes across all applications occurred when encountering either sizable tissue interposition between the magnets or anastomotic tension or both. These involve cases of perforation and restenosis after esophageal recanalization, unfeasibility to create intestinal bypass, postoperative stenosis after pull-through, restenosis after urethral recanalization, leakage and stenosis after urethral reconstruction. The pattern mechanism of MCA stenosis was considered to be related to insufficient magnetic compression, decreasing at excessive distance between magnets, which occurred because of bulky tissue interposition. Conversely, esophageal perforation was thought to occur due to forceful compression applied to extensive scarring when healthy tissue was not included in the compression gradient or healing zone. Currently, MCA advantages and challenges that we evaluated in our early experience appear to resonate with contemporary MCA issues. Recent MCA applications with the use of novel, more powerful neodymium magnets have been confirmed as safe and effective, in particular at the initial stage. However, the reported rates of subsequent stenosis and restenosis are fairly substantial. Adversely, in pediatric surgical application for esophageal atresia, post-anastomotic stenosis is the most common, up to 100%. Cases of anastomotic perforation have also been reported. In the meantime, there is only a handful of experimental studies considering the required magnetic force and compression. Notably, the optimal compression parameters in these reports are quite variable. In particular, the data of 2 experimental studies on intestinal MCA exceeds 3 to 10-fold the optimal range that had been estimated in our earlier experiments. We now propose to standardize safe and efficient MCA. More research into its biological formation should be undertaken to fundamentally establish the optimal compression parameters of required magnetic force and compression gradient according to the type of anastomotic tissue. As a result, specific anastomotic magnets with established physical characteristics should be designed and for each specific application with engineering input. Furthermore, an auxiliary magnetic driving device based on computerized technology should also be developed to facilitate intramural magnet deployment and to ensure optimal magnetic cooptation. This device, to prevent the risk of possible adverse events, would monitor in real time the applied magnetic force while measuring the actual distance between magnets and detecting undue anastomotic tension. In our view, MCA standardization with introduction of specific magnets and an auxiliary driving device will help to advance innovative MCA techniques, especially in combination with Mise technologies for their universal use in both pediatric and adult patients. And in conclusion, we confirm the rationale for MCA given its technical versatility as well as its higher biomechanical characteristics. MCA should be considered as a valid alternative to hands-on anastomosis for the future. Still, more research into MCA biology is needed to ensure efficient MCA formation without the risk of adverse events. Our proposals for standardization of MCA, especially focusing on Mise approach, are directed towards achieving the best possible patient outcomes. And in closing, I pay respect to our teachers, the great and innovative pediatric surgeons who initiated the early work with magnets and who inspired us and involved us in this project. Thank you very much.
Thank you. je ne sais pas si je dois le faire en anglais ou en français avec
En français, pour
Anatole.
est-ce qu'il y a des questions dans la salle pour le docteur
Dr. Anatole
Kotlowski?
I will translate for him.
Thank you.
Yes. So
Appreciate
maybe, peut-être que moi j'aurais un commentaire, une question, parce que l'école russe a fait ses publications dans les années 80 et à un moment donné, ça a cessé. Donc, je voulais savoir pour quelle raison cette chose a été abandonnée. Est-ce que le design était fait pour la chirurgie ouverte et que lorsque la paroscopie est arrivée, ça a cessé parce qu'on a vu la même chose avec le Valtrak, disons. So, my question for you, Dr. Anatole, is in the 80s, of course, the Russian teams were very progressive in doing this clinical application in pediatric patients and some adult patients. But why did they stop? Was it because open surgery went to laparoscopy, or what is your opinion on why this subject stopped for a while?
Well, thank you. That's a very good question. First, we went to the 90s, which was a really difficult time in Russia. And we had some just organizational problems in our institution. I personally left the country at that time. And well, the laparoscopy development, and you're absolutely right, perhaps interfered with some advancement of magnetic compression anastomosis in our institution. Really, the accent was shifted to laparoscopy at the beginning of 90s. But
yes,
at that time, when we still had laparoscopy at the very initial stage, we couldn't use magnets in combination with endosurgical techniques. But it could be a completely different situation now, and well, it is different situation now, and we can propose a combination of using magnetic compression anastomosis with endosurgical techniques.
Y a-t-il d'autres questions? Sinon, je vais aussi poser une question, puisque merci pour cette somme assez impressionnante de données et d'expériences avec les sutures magnétiques. Que pouvez-vous dire aujourd'hui de l'usage des sutures magnétiques? Y a-t-il un type d'anastomose qui vous semblerait le plus approprié? Et l'on a vu aussi qu'il y a un certain nombre d'organes sur lesquels ces anastomoses ont été utilisées. Quel est l'organe qui serait, selon vous aussi, le plus approprié pour utiliser ce type d'anastomose qui n'est quand même pas sans présenter des risques à la fois de sténose et de fuite? Thank you for presenting this large experience about magnetic anastomosis. According to you and according to the data you presented, do you think there is a specific organ or a specific type of anastomosis which would be more appropriate for using the magnets, which are not devoid of risk, as you shown with the strictures and leaks? What would the best use of those magnets nowadays?
Well, first, thank you for the question. First, as I mentioned, that magnets are really rational to use in situations of difficult surgical access. And the modern endoscopic and endosurgical techniques allow to use magnets now in this combination. In particular, from pediatric surgical view, the magnets are most popular at the moment for esophageal atresia repair in babies. And that's the most challenging. There's a very high rate of post-anastomotic stenosis after conventional repair, either by thoracoscopic approach or via open access, via open thoracotomy. And what actually the use of magnets allows us to avoid surgical invasion. The magnets can be used by purely endoscopic, with endoscopic access, avoiding, and that's particularly important for the really underterm patients and with complex conditions with underlying comorbidities. Another application for magnets I can see that might be colorectal resections, which are, I think, is not really progressing at the moment, but it's really, in particular, with laparoscopic mobilization, colorectal mobilization. That might be a good idea to use magnets. The magnets used for bariatric surgery, as it was mentioned, for gastrointestinal bypass or duodenal-intestinal bypass. That's perhaps at the moment the most important applications. But other, if we keep on developing MCA, we could use magnets for duodenal atresia repair, again, like it would be a combined approach, laparoscopic and endoscopic approach. And it could be some urological applications for correction of some congenital abnormalities.
Okay, thank you. So thank you very much, Dr. Kotlowski, for your presentation and for your time since it's pretty late at home. Thank you very much.
Thank you.
Thank you very much.